Welcome to Lesson 334. This is the last of the surgical courses. We started from Lesson 234, we went to 333, and we have come this far. So this is a continuation of the two courses, and it's made up of three systems. We're going to talk about the nervous system, musculoskeletal, and then the sense organs. And your main course instructor will be Mrs. Gloria Achimpim Anson, so I'm just a supporting lecturer for this particular one. So I'll go through the nervous system with you, and she will come and take over the last two systems. So within the semester, you'll be dealing with her more, since I'll also be with the 234 group. So we would start by talking about the nervous system, and we all know that we have cranial nerves, and because of that we do the neurological assessments. We'll talk about how to care for unconscious patients, and then we'll end the whole thing by talking about the spinal cord and the problems thereof. So your anatomy and physiology that you did at the diploma level, I suggest that you go and review your nervous system anatomy and physiology, and you also go over the functions of the cranial nerves. But that's a brief recap so it can help us appreciate the system better. We talk about the various nerves and what they specifically do. So I'll just go through some of them, and then you have a read of the rest. The first one, which is the cranial nerve 1, which is the olfactory nerve, is more concerned with the nose. So you have that nerve controlling the sense of smell principally. So it is a sensory nerve. Then the nerve 2, optic. Optic goes with the eye. So it's also another sensory nerve that controls the eye. And we know the optic nerve already, so it has to do with the eye. Then the 3, which is the oculomotor nerve, it also contracts the eyeball. So eye, ocular, remember that. And so we have several nerves that help in the function of the eye. The 4th cranial nerve, which is the trochlear, also has to do with the muscles of the eyeball. And then the trigeminal nerve is a Mace nerve. So the nerve 6 also helps with the eye. So the eye alone has several nerves that help it to function well. Then the facial nerve, nerve 7, is also a Mace nerve, and it helps you to change your facial expressions. So it helps in the contractions of muscles, and also helps you to salivate and also to cry. Then the nerve 9 and 8. The nerve 9 has to do with the ear, the inner ear, and the nerve 8 has to do with the inner ear, and the nerve 9 is also a Mace nerve, has to do with the tongue and the pharynx. So when you read the rest, take notes of the vagus nerve, which is nerve 10, and that has to do with the heart. So try and read all the nerves so that you'll be familiar with what they do for us, so that if a patient has a problem with one nerve, you know what to do best for that patient. So moving on to assessment of the system, the neural system. We focus on the patient level of consciousness, whether the person is deeply unconscious, semi-conscious, or conscious. We also handle the eye, whether the people react to light or not. I mentioned just a moment ago that the vagus nerve controls the heart. So you can't do an assessment of the neural system and leave the heart out. So if you have a firm grip of the nerves of the brain and what they do, you can close your eyes and assess the patient, because you know what the nerves are supposed to do. So then your assessment will be geared towards these things. So we do the vital signs, including the heart rate. We want to know how the muscles can contract or not. We want to see whether a person can respond to stimuli. If you touch me on the face, will I know? How am I posturing? So because of that, we have the Glasgow Coma scale that help us to score when we do the neurological assessment. So the eye opening, the verbal response, the motor response, we have the scores attached. So we have 1 to 4. So if a person cannot open the eye at all, it's 1. If the person opens the eye spontaneously, it's 4. The motor response, if the person cannot move anything at all, contract anything at all, is 1. So you see that the various parameters, they have the scores attached. So you should be familiar with this neurological assessment scale, which is the Glasgow Coma scale, to help you in your practice. Now, when somebody has something wrong with the neural system or the nervous system, what are some of the manifestations that you can see? For some of them, the person cannot walk. Person will be shaking, wanting to fall. Person cannot balance well. Then the person will feel numbness, depending on the parts or the particular nerve involved. So either the person will have some tingling sensation, abnormal sensation, pins and needles, or no sensations at all, depending on what is wrong. Remember, I also mentioned optic nerve. So the person can also have things wrong with the eye. Person may see double or cannot see, blurred vision, etc. Then the person will feel very tired, tremors, paralysis, pain, sexual dysfunction, etc. So there are several clinical manifestations of the nervous system. And remember, because it's the brain, you have things to do with depression, emotional changes, etc. And a person may not be able to write well. Some of them forget easily, or they become disorientated. And so there are several of them, and I suggest that you take your time to read all of them so that you become familiar with these things. Now, what are some of the things that can predispose you to have a nervous system problem? One key one is a high blood pressure. If you have a very high blood pressure and the pressure against the cerebral vessels are so high, you could have a vessel rupturing, and so then you are going to stroke, etc. But then, for the particular nerve to be fed to function appropriately, that nerve needs maximum supply of nutrients. So if you have high blood pressure, which is interfering with your circulation, then you are at risk. Then you have physical inactivity, you take a lot of alcohol, there's something wrong with your heart, diabetes, smoking, you have it in the family, high cholesterol level, you are fat. All these things can predispose you to have a nervous system disease. Therefore, when you have a patient come to you unconscious, as a nurse, there are several things that you can do to help that patient. But remember that hearing is the last sense to leave the body. So no matter how deeply unconscious you think I am, when you are around me, taking care of me, then you should be able to, know what you are saying, because the person can hear, no matter the unconsciousness level. Hearing is the last sense to leave the body. So you come to me, and even though I'm unconscious, please call me by my name, Dr. Lydia Aziato, or if at that time I'm a professor, you say Professor Lydia Aziato. Don't worry. Don't just say the unconscious woman lying there. It's bad. So mention my name. And you say things that is encouraging, trying to move the person from that deep pit to come back to life. So if there's something that is depressing to discuss, do not discuss it in the presence or around the bed of an unconscious patient. So what is wrong with me before I became unconscious would inform the care that you give. And of course, you all know that for unconscious patients, the position that you put the patient is very critical so that the person will not aspirate. So if you are putting me on the side with my head turned and you protect my pillows so that even if I'm salivating, I will not soil for the place to be smelly. You do all that and make sure that you keep an eye on my vital signs. You use a Glasgow coma scale to check my level of consciousness, and you make my environment comfortable. Remember that I can easily develop bed sore. So if I'm unconscious, you need to change my position every 2 hours, and you treat my pressure areas every 4 hours. It's very, very important. You should also be able to use the necessary bed accessories to help in the care. So extra pillows, sandbags, whatever you have that can make the patient comfortable is very, very important. Then you must maintain my airway patent. So for most of the patients, you need to suction, and some of them you even need to give oxygen. And some, in extreme cases, they are intubated. So after taking care of my airway, you need to feed me. All right, so most of the time, the patient will be on IV therapy. So you have to make sure that the site of infusion is not tissued, and you maybe pass an NG tube to feed if it's not contraindicated to whatever is wrong with me, and make sure that you maintain the input and output record. And if there is any problem regarding my electrolytes, you need to add these electrolytes to the IV fluids that you give me. So it's important that you remember how to care for the patient. Now, regarding the skin and other personal hygiene activities, once you bath the patient, now you use diapers. Okay. If you use the diaper, you don't keep the diaper on 24 hours. If the diaper is soiled, please change it. If I'm catheterized and you need to change the catheter, you have to prevent infection. It's important that when I recover from the unconsciousness, I will not have other problems because of neglect. So you take care of the skin, you ask the relative to bring some Vaseline so you can lubricate the lips so the patient will not have cracked lips. And if you are taking care of the skin, please be careful, because sometimes early signs of skin breakdown, if you are too aggressive, you rather precipitate the breakdown of the skin. So when you are caring for the skin, you observe for signs of skin breakdown and you report so that the person can be helped with the right cream or whatever medication. Then you apply so that the person will not have bed sore. If you have bed sore, it's very, very, very disheartening, and it shows that the nurses on the ward did not care for the patient very well. Now, regarding elimination, the person may eliminate bowel or urine, feces or urine. So if you have an unconscious patient, you know the person cannot talk. So you have to be the one observing. You don't keep the person there the whole day and you don't go and check the diaper to see whether it's soiled or not. So you must make sure that you take care of the elimination needs and you observe the whatever the patient has eliminated and you record in your nurse's notes so that if there is any problem, it can be solved. Now, for some of them, for days on end, no feces. Perhaps there is impacted retained feces. So in that regard, you need to wear gloves, lubricate your finger, position the patient, and scoop the feces out with your fingers. It's very important that you remove the impacted feces so the person can have some relief. The urine. If the urine color is so concentrated and the amount is very scanty, it means that perhaps the person is not having enough fluid intake. You should discuss with the doctor in charge so you can give more fluids. It's important you watch this out. And sometimes if there are other complications, like you have problems with the kidney or the liver, then you have to take very good care of the urine and observe and make sure that the person is not, the person's health is not being compromised. I mentioned that you have to use some bed accessories. For example, you can use a footboard or a sandbag to prevent foot drop of the unconscious patient. So when you do all that and you are sure that the person is not having any other major challenges, then you must make sure that if there is any investigation to be done, like supportive care, as in lumbar puncture, you help to take the sample so that if the person needs some particular drugs, it will be given. Some unconscious patients can also fit. So sometimes they give them anti-epileptic drugs. Other times they give them some steroids. And those with serious problem with constipation, they are also giving stool stopnets to help them move their bowel. When a person goes for surgery, any surgery at all, and the person becomes unconscious, you continue with all the care areas that I've mentioned. But then you have to also take care to make sure that you do not get further complications for issues of increased intracranial pressure. So you have to observe the eye to see whether the person is becoming edematous or not. And you keep particular eye on the vital signs and the oxygen saturation so that at the end, when the person finally recovers, the person will be better. In fact, the complications of neurological system surgery is so much. Sometimes they become psychotic, sometimes they can just pop off. So you have to be sure that you don't compromise on the care of a patient who is unconscious post-nervous system surgery. In case you have any problems with the lungs, you also need to make sure that you do exercises. So sometimes you have to involve the physiotherapist to come and help the person exercise gently, sometimes the chest, sometimes if the person is a little, can hear or do a few things for himself. You know you have levels of unconsciousness. So this is the continuum of somebody who is deeply unconscious and somebody who is semi-conscious, improving to consciousness. So depending on the stage that you have the person can do deep breathing and coughing exercises, sometimes as mild as they can, to help expand the lungs. So these are the few things I can say for now, and I suggest that you read more so that you can care for these patients better. The last of this first session is on intracranial pressure, and it's a very common phenomenon on the surgical ward for patients with brain tumors and other challenges with the CSF or the cerebrospinal fluid. So we all know that in the head, in the brain, and around the spinal cord, we have what we call the cerebrospinal fluid. So the cerebrospinal fluid is an important part of our physiological processes. And if you have the space that it occupies being very full of the fluid, it puts pressure on the surrounding organs. And when you have a very high pressure within the fluid, sometimes it can push the brain to pass through the foramen magnum. So you have a herniation of the brain. And this is a very, very, very serious situation. So we don't want that to happen. Therefore, we need to watch out for signs that show that perhaps there's increased intracranial pressure. So we can do something about it before the brain would herniate through the foramen magnum. So in that instance, if you have a patient on your ward with a nervous system problem, the brain and the spinal cord, I was conscious and all of a sudden I'm becoming confused or I'm losing consciousness. It's a sign that perhaps there's something wrong with my intracranial pressure. Then sometimes the person cannot respond to stimuli. Like you touch the person doesn't even know you have touched him or her. The person is confused, restless, not knowing where he or she is. And nothing has happened, the person is sleeping. And some of them will complain of very, very severe headache. And some of them will vomit. So they will complain that the headache even become worse when they cough, sneeze, or when they strain during defecation. And other times you see the eye, around the eye is edematous, it's becoming swollen. And there's some change, the person cannot react or respond appropriately. So these signs plus others that you have on your slides show you that maybe the person is having an increased cerebral intracranial pressure. So if that happens, you have to quickly take your things to check the person's vital signs and do the neurological assessment. Remember that if you use a scale, it's more objective, so you can report appropriately what your findings are. So always keep the particular dimensions of the Glasgow Coma scale on your fingertips. Then if the person had become unconscious, maintain patent airway. Airway is so important because if you have a problem with the airway, then you are dying. So you must make sure that your patient has always a patent airway. Now, depending on what is wrong with the patient, some drugs may be administered. Key among them is what we call the mannitol. The mannitol is like osmotic diuretic. So when you give it to the patient, it helps to reduce the fluid. The patient will urinate more, so the pressure in the brain would reduce. Then corticosteroids that we know of, normal prednisolone, for example, also helps to reduce cerebral edema. Other drugs could be antibiotics, depending on what is wrong, dilating, or sometimes other drugs are given like analgesics. For example, if I'm in pain, severe headache, the doctors may add some analgesics to it. Now, you do not prop the head up very high. The recommended angle of elevation of the head of the bed for somebody with intracranial pressure is 30 degrees. So keep that in mind. You don't prop the person up. Person becomes more confused because of the gravity effect. So 30 degrees elevation of the head end of the bed is okay. So with that, sometimes the patient, even though you have elevated the bed, if the person is unconscious, you put the person, the normal recumbent with the head turned to one side. So it's important to keep that at the back of your mind. Now, when you give the person the necessary drugs and all that, you also have to make sure that nothing is blocking the airway. So you administer all the things that you have to administer and also make sure that you secure the airway with the necessary items that you have on the ward. Don't forget that a person can fit, so make sure you protect the sides of the bed so that the person will not fall down. So side rails is important to use. Then the patient's education. If you have a patient who has been discharged after a head surgery, educate the patient to report any of the following problems immediately, because it could be a sign that there's increasing intracranial pressure. Some of these things include high temperature. You teach the person how to check the pulse. So if the pulse is dropping 50 beats per minute, less than that, it's dangerous. You have not eaten anything and you are vomiting. What are you vomiting? There's something wrong. You are speaking and your speech is kind of slow. You can't say the things you want to say at the speed you want to say it. Please come back to the hospital. You are not hungry and you are feeling dizzy. You can't see well, and you can't control sleep. 1, 2, you are sleeping. There's something wrong. And if you start convulsing, after that one, you have to run and come to the hospital immediately. So you also educate the patient and the family so that in case of anything, they bring the person to the hospital as soon as possible. So with this first session, it is important for you to know the cranial nerves and what they do, how to assess a person neurologically, and then we've also discussed just now how to care for a patient with increased intracranial pressure.